Our next section is COPD, alpha-1 antitrypsin deficiency, and let's throw in some gooey bronchiectasis into this section. COPD, which I'm going to use very much synonymously. I'm not a big fan of breaking up COPD into chronic blue bloater, chronic bronchitis, and emphysema, and the reason is that it doesn't change the testing, it doesn't change the treatment very much. So for me, since it doesn't change the answer to what is the best initial test, what is the best initial therapy, what is the most accurate test, PFTs, what is the best initial therapy, muscarinic antagonist and albuterol. Since it doesn't change the answer to those questions, what decreases mortality? Stop smoking and oxygen, stop smoking and oxygen. Since it doesn't change the answer to those questions, I'm not going to break them down very much. Since they're both in long-term smokers, since they both have increasing shortness of breath and decreased exercise tolerance, particularly as people age, I'm not going to break them up because it doesn't change it that much. Now, acute exacerbations of COPD, the oxygen and arterial blood gas. This is everybody. Put this on the whole first screen. This is what you put on the first screen. This is what you put in the first screen. Now, don't worry about that thing that some of you may be worried about, the giving too much oxygen to the person who's CO2 retaining. Hey man, I heard that if you give too much oxygen to the person who's CO2 retaining, they'll have respiratory failure. Don't worry about it. He's an anaerobe now, man. He can't breathe. He's hypoxic. You got to give oxygen to the guy who's hypoxic. Give oxygen to the guy who's hypoxic. So this is what goes on the initial screen with all COPD patients. Inhalers, and right away ipratropium. Ipratropium is the acute version. Tiotropium is the longer one. Tiotropium is the longer one. Ipratropium is the acute muscarinic receptor antagonist, acute muscarinic receptor antagonist. And this is the biggest major indication for it is COPD. Now this may look almost exactly like acute asthma exacerbation management because it's very similar. It's very similar. In the same way, theophylline won't work acutely, chromondocarum won't work acutely, omalizumab won't work acutely, montelukast won't work acutely. Yes, they are very similar. So now you're choosing the pieces of the physical examination. And in choosing the pieces of the physical examination, you should do all of these. Now, step 3, CCS, is not going to fail you for getting a little extra piece of physical examination. Let's get physical, physical. I want to order a physical. Let me get some extra parts and I won't fail my test if I order more than the rest. Yeah, it won't. Let's get physical. And therefore, you see, all the times that you have, remember, no matter what the case is, they get 1 minute for the heart, 1 minute for the chest, 1 minute for the extremities, 1 minute for the neuro exam. Order them extra. If there's sputum or a new infiltrate, you're going to treat community-acquired pneumonia. Ceftriaxone, azithromycin, ceftriaxone, azithromycin, same as every other community-acquired pneumonia. If you've been treated with antibiotics, if you've had a lot of exacerbations, quinolones, levofloxacin, gadifloxacin, levofloxacin, moxifloxacin, levofloxacin, moxifloxacin. Now, remember, in COPD, the arterial blood gas is more important than asthma because in COPD, you need to assess the carbon dioxide level. In asthma, you don't as much, but in COPD, the only way you can tell am I retaining CO2 is the blood gas. That's why it's much more important. Now for CCS, for acutely ill patients, don't move the clock forward 2 hours. In CCS, for acutely ill patients, hypotension, chest pain, shortness of breath, chest pain, shortness of breath, hypotension, confusion. For acute unstable patients, don't move it more than 15 or 30 minutes and redo the oximeter. No one's ever going to get into trouble by redoing the oximeter too much because it's an oximeter, not a blood gas. Now, if there is some respiratory acidosis, you've got to increase the ventilation. And how you increase that ventilation is with CPAP and BiPAP. That's how you increase that ventilation, with CPAP and BiPAP. You increase the ventilation with CPAP and BiPAP, and you move the clock forward. If there's CO2 retention that's still not improved and they have a respiratory acidosis, now the key issue is how are you going to know whether the CO2 retention is chronic and okay, or whether the CO2 retention is like life-threatening and you're going to die. How are you going to tell whether the CO2 retention, maybe you've had that CO2 retention for 5 years. No, maybe it's acute and you're going to die. How do you know whether to go into ICU or go home? You'll use the pH. If you have chronic CO2 retention, your pH is normal. Because what's the compensation for CO2 retention? The compensation for CO2 retention is that the kidneys will retain bicarbonate. So therefore, you'll use it if people have a low pH. If it's just CO2 retention alone, don't intubate. No, don't intubate if it's just CO2 retention alone, because they have chronic CO2 retention. Now, if there's a worsening pH, then you have to intubate. Worsening pH is a respiratory acidosis, then you have to intubate. But the bicarb will tell you. The serum bicarbonate is the one that will tell you. The serum bicarbonate will tell you, is this acute? Acute, the bicarb is normal and the pH is down. Chronic, the bicarb will be up as compensation. The bicarb will be up as compensation. Now, on the physical part of the CCS, it's often hard for people to understand how much physical to order. First of all, you, on any acutely ill person, will never lose points for ordering an extra piece of heart or lung exam or abdomen. But before you do, you have to ask yourself the question, it's not if the exam comes back normal. It's the question, what could it have shown? And you're going to ask yourself this question in CCS. If that piece of physical could have been abnormal, then you'll order it. Oh, but it was normal. I lose points. No. It could have shown clubbing of the fingers. It could have shown a loud P2 from pulmonary hypertension. It could have shown edema from right ventricular failure. So your question will be this. How do I know how much physical to choose on CCS? You choose it based on what could be abnormal. If there's a possibility that it could be abnormal, then you'll order it. Could it show clubbing? Then you'll order it. Could it show barrel-shaped chest? Then you'll order it. Could it be abnormal? Then you'll order it. Could the EKG show right atrial hypertrophy, right ventricular hypertrophy, right axis deviation? Right side, from pulmonary hypertension. It could have been abnormal, then you'll order it. Could have had right bundle, could have had sign of big P waves. Look at that big P wave. It could have been abnormal, then you'll order it. That is a biggie because people sometimes think that everything's got to be abnormal if they order. No. CCS, computerized clinical case simulations, wants you to understand a process. And the process is, dear doctor, before we grant you this medical license, we want to make sure that on every disease, you know which parts of the body to examine, whether they're normal or abnormal, which tests to get, whether they're normal or abnormal. We want to make sure that when you're a doctor, you don't miss anything. And that's why the chest x-ray you'll get on every COPD patient. Barrel chesting, flat diaphragms, thin heart, barrel chest, thin heart. Oh, well, what are we seeing here? Well, we're seeing a normal x-ray over here, an abnormal over here. Oh, we're seeing a person, you see the circled things? Well, you see what this is? That's Buddha, Bulle, Bulle, Buddha, Buddha, Bulle, Bulle, Buddha. So, in COPD exacerbation with emphysema, the CBC is increased as a sign of chronic hypoxia. And what happens is that the person is microcytic because chronic hypoxia is one of the reasons that polycythemia, increased cell count. Now there's 3 things only that cause an increase in cell count, but a decrease in cell size. One of them is hypoxia. The other is polycythemia vera, the hematologic malignancy. And the third thing, with an increase in number and a decrease in size. an increase in number and a decrease in size, is thalassemia. Now, thalassemia doesn't get mixed up with this because thalassemia at the end of the day is anemia. But people who have a microcytic erythrocytosis can be hypoxic or polycythemia vera. The bicarbonate is compensation for the respiratory acidosis. This is a perfect example of saying, I'm going to order things not based on whether they actually are abnormal, but that I know what could be abnormal. I know that COPD is one of only 3 causes of microcytic erythrocytosis. Increased count, small cell size. Blood gas, even in office-based cases, because you have to assess CO2 retention and pH. You see, the other part is, it's only if the PO2 is less than 60 that you use home oxygen. PO2 less than 60 or saturation less than 90%. PO2 less than 60 or saturation less than 90% for home oxygen. So that's why you have to have that blood gas to see if there's a PO2 less than 60 or a saturation less than 90% as indicating the need for home oxygen. So this is it, COPD, decrease in the FEV1, decreased FVC, but the FEV1 is decreased even more. It's decreased even more as opposed to restrictive lung disease where they'll both be decreased, but they'll be decreased proportionately. You have an increase in the residual volume because what ends up happening in COPD is FEV1 that you normally use, breathing minute to minute, gets transferred into flattened diaphragm and residual volume. And you get a decrease in your carbon monoxide diffusion capacity because your lung parenchyma has been destroyed. The lung parenchyma has been destroyed. Now these criteria, I hate making people memorize names like this, but that's the name. It basically says that your FEV1 here, okay, it still stays up there, but your FVC is down. And then the lower the FEV1, the more severe disease. The lower the FEV1, the more severe disease. Okay, the lower the FEV1, the more severe disease. That's what gold criteria. Don't you wish you had your name put on this? Well, man, you get to be a genius, right? You get your name put on a criteria called it's evil. In evil 1, evil 2, evil 3. So pulmonary function test, you see, the obstruction is over here. This is saying a decreased FEV1. See, a normal person starts here. Ready? You breathe in. But the person with COPD inhales. Ready? And that's how it is, COPD. That's right. COPD looks like a C. COPD, saying decreased FEV1. Decrease in your FEV1. So what happens here is that you get a decrease in your FEV1 and decrease in forced vital capacity. Both are decreased, but which one's decreased more? The FEV1 is decreased even more. What happens to your total lung capacity in COPD? This is the most common wrong answer. Your total lung capacity actually goes up. Well, what do you mean? I thought you were sick. How can your total lung capacity go up when you're sick? Because it all turns into crap. It turns into residual volume crap that you can't use. Because you may be having a total lung capacity, but your DLCO goes down and your residual volume goes up. So what happened is that your lungs being turned into total lung capacity, that's all crappy, useless residual volume. Now, the initial therapy for the chronic thing in COPD, the inhaled muscarinic antagonist, tiotropium, ipratropium, muscarinic antagonists. That's where they're best. In other words, tiotropium, ipratropium, you'll never get asked to choose, hey, should you use tiotropium, ipratropium, or albuterol, but it's really the question you can say, in what disease is a muscarinic antagonist the most effective? In what disease is a muscarinic antagonist the most effective? And the answer is COPD. Everyone with COPD gets pneumococcal vaccine. You don't have to wait till you're 65. If you have COPD when you're 50, when you're 48, when you're 52, you need the pneumococcal vaccine because everybody with chronic heart, lung, liver disease needs a pneumococcal vaccine. Everyone with chronic heart, lung, liver, kidney, and cancer needs pneumococcal vaccine. And everybody gets vaccinated every year for influenza. But what's the question for COPD? The question is, in which of the following groups will derive the greatest benefit from influenza vaccine? Which of the following groups will derive the greatest benefit? So you could say it's everyone every year. Yeah, but who gets the greatest benefit? Why does it matter? Well, because I want to know who we should chase down the most. You want to know where, okay, do you have an unlimited amount of money and time and effort? Well, why don't you chase the most vulnerable populations? Who's the most vulnerable population for influenza? How do you die of influenza, by the way? Pneumonia predisposes you to pneumonia. Who predisposed to pneumonia? People with COPD. So there's an excellent question of which of the following groups of patients is most likely to derive the greatest benefit from pneumococcal vaccine. And smoking cessation too, for that matter. So that question actually would be, if they showed you this question, who gets the greatest benefit from stopping smoking? Which group gets the greatest benefit? COPD by far. Because one of the things people don't understand is, for every person that dies of lung cancer, 2 people die of COPD. 150,000 people a year, 3,000 a week, die of lung cancer. But 300,000 people a year die of COPD. For every person that dies of lung cancer, 2 die of COPD. So long term, now this is the most stringent of the criteria, PO2 less than 55, saturation less than 88. However, if you have pulmonary hypertension, it's O2 of 60, SAT of 90. If you have polycythemia, O2 of 60, SAT of 90, needs oxygen. If you have any signs of illness, like pulmonary hypertension, polycythemia, right ventricular hypertrophy, PO2 less than 60, saturation less than 90%. That's who needs the oxygen the most. And it lowers mortality. Which of these lowers mortality in COPD? Smoking, home oxygen, and the answer is both. Both of these. This is why I'm saying it again. I'm saying it again because this is one of the most important things, because interestingly enough, it's actually much better than albuterol. Albuterol doesn't lower mortality as much as the oxygen and knocking off your smoking, Mr. Chimney Face. Okay? See, almost all of these people can tolerate beta-1 specific drugs. That's why if you need it for your heart, you'll use it. Alpha-1 antitrypsin deficiencies. Next disease. Well, this is actually very simple because you got alpha-1 antitrypsin. It's basically COPD in a young person who doesn't smoke. COPD in a young non-smoker, and it's also combined with liver disease. COPD in a young non-smoker, and also the family history if they want you to know. Liver, lung, genetic. And basically you say, why is this person at the age of 35 having COPD, particularly if they don't smoke? Smokers get it even earlier. Why you got COPD at a young age? I don't think it's too much of a diagnostic question, and step 3 tends to say, hi, here's a 35-year-old guy who has shortness of breath, an abnormal x-ray, he's got some cirrhosis. And why is it that you got a non-smoker who's got bullae? And also at the bases too. Why you get bullae at the bases? Alpha-1 antitrypsin, this is a list of all the things that you have in it, gives you some liver problems. And although it's associated with some kidney things, the major thing is to understand it's lung and liver and lung and liver. And you can actually fix it by just saying, hey, are you missing it? You got the COPD, you got this at a young, and you see a low level of it. You see a low level because there's low levels of albumin and abnormal clotting factors. And you see a low level of alpha-1 antitrypsin. Hey, doc, it hurts when I do that. Well, don't do that. Hey, doc, it hurts when I don't have alpha-1 antitrypsin. Well, then take some alpha-1 antitrypsin. Hey, it hurts when I don't have alpha-1 antitrypsin. Well, take some alpha-1 antitrypsin. Actually, there's not much more than that for you to know. Now, bronchiectasis is a rarer disorder in our society because we have better access to care for children, and children don't get rubella like they used to. That's where a lot of bronchiectasis used to come from viral infections and diphtheria in kids. And people don't understand when you have that growing, soft, mushy, healthy lung in the babies and 30-year-olds and 5-year-olds and 7-year-olds. Those kids who had what are now we consider vaccine preventable diseases, well, those kids used to get deformed bronchi. And those deformed bronchi used to cause anatomic defects in the lungs from things like infections, like pertussis, rubella, that made the lung abnormal, and you couldn't do anything to reverse it. You couldn't fix it. So you'd be coughing up cup after cup after cup of bronchiectasis by the cupful. And all you can do is just treat the infections as they come up. So what they end up doing, by the time they're 20, they got 50 gazillion resistant infections. So it's a big dilation. It makes basically your bronchi become like Florida swampland. So your lungs become all Florida swamplandy in there. And it's just the gunky stuff. And the cilia don't work. See, one of the people don't realize is that when you breathe in something bad, some carbonaceous thing, dust even, you cough it up. You have cilia, and the cilia are like having a shag rug that moves. In the future, we won't need garbage cans. Just throw it on the floor, and the shag rug will move. And then it comes up to your near your mouth, and you either cough it out or you swallow it. You don't even know that you're swallowing it. Did you know that one cigarette is enough to paralyze that cilia for 24 hours? One cigarette is enough to paralyze those cilia for 24 hours. But what if you have a lung infection as a kid that damages the anatomy of your bronchi and makes it that the cilia literally can't move upside down if you have bronchi that are like upside down? And you get this huge high volume of sputum by the cupful because instead of nice bronchi in straight lines, you've got these cups and swamps and anatomic defects that you just can't clean out. And you cough and you cough and you cough. And remember, anything that causes a chronic cough can cause hemoptysis. This is even worse since it really inflames your bronchi. Now, clubbing is unusual, so that's not the relevant thing. You won't miss the thing with bronchiectasis because the basic issue is it's going to be a lifelong thing. It's often from childhood. Now it happens a lot from foreign bodies. I should say the number of them are foreign bodies and is more common because there's not as many of those infections in childhood. The bronchi are badly dilated and the CT scan will show it. The CT scan will basically show, on high resolution CT, will show that you have really dilated, look at that, it's a fantastic picture, isn't it? Tram tracking? Because this is an anatomically dilated bronchus, and ultimately, how do you fix it? Well, you can't. You can't. You can't. Look at all this crunchy, look at the holes and nasty stuff over there. You can't fix it. You can't reverse it. All you can do is, treat the infections as they come up. But you have nothing to reverse the bronchiectasis. You can do cupping and clapping and that's what I do. Or take a week of antibiotics. Rotate the antibiotics around so you don't get resistance. Bronchiectasis is an anatomic defect in the bronchi that makes secretions pool. It used to be from infections. Now it's from foreign bodies that dilate the bronchi. And you treat the infections as they come up and do chest physiotherapy. I'll see you in the next section.